As we know, the mutational subtypes in pancreas cancers are mostly heavy in G12D mutations, followed by G12V and G12R. And the G12C mutations occur very seldomly, 1 to 2%. And as Tony has previously explained, this is a type of allele mutation that is heavily relying on hydrolysis, and therefore it's more common to be able to be intercepted in the off state, and it doesn't really become GTP active as much as the G12D VNRs. So there was a recent paper by Ryan Corcoran and collaborators in Cancer Cell looking at the variety of KRAS G12D and G12P structures and how the different inhibitors actually bind, with the off inhibitors targeting the switch 2 domain, and the on inhibitors, many of them acting on a molecular glue, the cyclophilin A interaction with a GTP domain. So very different mechanisms of actions and where these inhibitors bind. And are they on and off, only off? So we think that the mechanisms of interaction with KRAS is really important in terms of how effective they might be. Now, there are many, many types of KRAS inhibitors, and again, if you're curious, I invite you to read this paper because it explains to you what a tri-complex inhibitor versus a switch 2 inhibitor is like and where do they bind, and the different types from various pharma companies of on and off inhibitors to date. One of the most interesting papers that I've read recently is from the Ben Stanger's group in Science. The fact that KRAS inhibitors, by targeting the acinar ductal metaplasia as well as a panning evolution, may actually prevent the formation of pancreatic cancer. This is, of course, preclinical models. Mice treated with Revolution Medicines G12D as well as G12D and G12 pan-RAS inhibitors actually arrest the formation of pancreatic tumors if you treat them in that panning stage or early cystic neoplastic stage. We can start with some G12C inhibitors because they were first on the block, and this is data from sotorasib in KRAS G12C mutated pancreas cancer, pre-treated, response rates of 20%, survival rate median of about 7 months by John Strickler et al. Tony presented data with adagrasib in many solid tumors, including pancreatic cancer patients, looking a little bit better than sotorasib with response rates for pre-treated pancreas cancer, about 30%, and an OS of about 8 months. Olomorasib here looks maybe slightly superior with a PFS about a month and a half better than adagrasib for G12C, and it also appears to have some efficacy in G12C pre-treated patients. So this is quite interesting data in, again, new generation G12C inhibitors in pancreas. Now, the Revolution Medicines group had been obviously the pioneer in discovering the pan-RAS, the molecular glue, the tri-complex molecular glues of G12D and pan-RAS inhibitors. And these are preclinical data showing that the pan-RAS inhibitor RMC-6236, also called daraxonrasib, really affects all of the types of KRASs, G12s, G13s, Q61, NRAS, and HRAS. So this is an agent that's not just effective, or it's not supposed to be just effective in KRAS mutated pancreas cancers or solid tumors, but also beyond codon 12, as well as for NRAS and HRAS. And then to the right, you have the different models for lung cancer, colorectal, and pancreas. This is data for second-line treated pancreatic cancer with daraxonrasib, with response rates of about 30%, and disease control rate above 90% in pre-treated patients. Survival, to the left, we have progression-free survival curves of about 8 months median, and overall survival of about 14, 15 months in second line for pancreatic cancer. And this is far better data comparing with frontline pancreatic cancer regimens with chemotherapy with NALIRIFOX, FOLFIRINOX, and gemabraxane. The RASolute 302 global study of daraxonrasib monotherapy versus investigator's choice chemo in second-line pancreas cancer completed accrual. And we are all super excited to hear results. We hope that this summer. And if the results are as good as we hope them to be, we expect to see an FDA approval of this agent in 2026 for second-line pancreatic cancer, irrespective of RAS mutation status. There is a G12D allele-specific inhibitor from RevMed, zoldonrasib, also looking good with response rates of about 30%. And I didn't show here, but there are studies combining zoldonrasib with daraxonrasib to see whether response can be even better. A new, different mechanism of action, proteasome inhibitor from Astellas, ASP3082, now called setidegrasib, has been previously reported by Woongi Park to the left as monotherapy in pretreated G12D pancreatic cancer, response rates of about 20-25%. To the right, we have data presented by Anup Kasi from Kansas at ASCO GI 2026, showing response rates as high as 60% in combination with FOLFIRINOX, with this a protein degrader for G12D. By the way, a phase 3 study by Astellas with that agent in combination with chemotherapy, either FOLFIRINOX or gemabraxane, is launching or has already launched this year. In terms of other G12D inhibitors, we had seen at ESMO in 2024 and 2025. From Insight to the left, we have INCB 161734 agent from China. In the middle, the monotherapy with HRS 4642. And also from China to the right, in combination with gemabraxane, response rates with monotherapy about 30% across the board, and in combination with chemotherapy, and this is frontline, response rates go up to about 60%. And as you can see in the graph below to the right, some of these responses are and benefit are long-term. Progression-free survival is not reached. It's very premature, but has not been reached to date. Now, Dr. Zev Weinberg from UCLA has presented at ASCO GI this year the Insight 101 study, which really has a phase 1 dose escalation as well as dose expansion of 2 different doses of the Insight agent, as well as combination therapies with chemotherapy, gemabraxane or FOLFIRINOX. And there were very few patients treated, but this is the data that had been presented. Again, response rates of about 37% to the left as monotherapy. And to the right, we have the combinations with gemabraxane GA or FOLFIRINOX FX. And you can tell based on the prior lines of therapies, if it says 0, that means these are frontline metastatic disease patients. And if it's 1, that means it's a second-line patient. So again, few patients, few numbers, response rates in the order of 50% at the dose of 1,200 and about 30%, but there are only four subjects at the 600 milligram dose. So again, a phase 3 study is ongoing. Now, very excitingly, and I wish that this meeting occurred next week or 10 days from now, because Brian Wolpin is going to present at AACR a new data with the Revolution Medicines RMC-6236 daraxonrasib as monotherapy in first-line pancreatic cancer. This is data that's available publicly on the RevMed website, and it's not the most updated one, 47% response rates in first line with Dara alone. To the right, we have the combination of Dara plus gemabraxane with response rates of about 55%. As you can see, the disease control rates are 90% either way. So this data looks, again, extremely promising, and looking better even with daraxonrasib alone, better than FOLFIRINOX in frontline. Resolute 303 is Revolution Medicine's first-line study comparing gemabraxane standard of care with gemabraxane plus daraxonrasib at a 200 milligram dose. Gemabraxane in this study is dosed only every 2 weeks for tolerability, mostly for myelosuppression. And DARA alone is an option. So patients are randomized 1:1:1. This is a 900-patient study which has already launched. And it will be very exciting to see if, I can tell you, many patients in my practice wish to enroll in this study and they really hope to get DARA alone. They are not looking forward to get any chemo or even the chemo combination arm. So again, very exciting to see these data coming up. And I am not, showing you all of the studies going on with DARA or other KRAS inhibitors in pancreas cancer because there are numerous. But suffice it to say that we're taking this approach in the adjuvant setting, in a setting where we can hopefully cure patients. And patients with pancreatic cancers in Resolute 304, after they complete either neoadjuvant therapy followed by surgery or surgery followed by adjuvant chemo, will be randomized 1:1 to either observation or maintenance therapy with daraxonrasib. This is a study that will accrue 500 patients and looking at disease-free survival. Resistance occurs as we have seen mechanisms of resistance to G12C inhibitors. Similar mechanisms occur to pan-RAS inhibitors as well as G12D inhibitors, and most of them are KRAS alterations. New mutations occur, but in addition to new KRAS alterations, we also see 37% of the time upregulation of receptor tyrosine kinases, for instance. We see KRAS amplifications, PI3 kinase or MAP kinase alterations, but those are slightly less frequent than new KRAS pathway alterations. Now again, we alluded to the fact that KRAS shapes the tumor microenvironment in pancreatic cancer. And there is preclinical data that targeting KRAS can basically reverse immune evasion. And therefore, we do expect that after we treat a patient with a G12C or G12D inhibitor, maybe they may respond even better to second-line or third-line therapies, and combinations with immune checkpoint inhibitors are certainly ongoing. We have also seen that small molecules are not the only way of targeting KRAS. There are multiple trials using immune therapies that target KRAS, such as adoptive cellular therapies, TCR, T-cell receptor, chimeric T-cell receptors, T-cells that target KRAS G12D. This is a paper by Ron Liner from Providence in Oregon, showing some response in a patient with metastatic pancreatic cancer with lung metastases, granted small lung metastases. This patient had a response to the TCR targeting G12D. We are doing at University of Washington with the help of Phil Greenberg, these G12V targeting TCR T-cells that are very geared towards HLA-A1101 positive patients. So you have to have this haplotype because the TCR actually is obtained from a healthy donor that had the HLA-A11 blood type. So this is limited to this patient population. About 10% of Caucasians have HLA-A11. About 30 to 40% of Asian populations have this haplotype. And this study is ongoing. I have to tell you, we do see responses, albeit they are temporary responses obtained with these infusions. Excitingly, the Memorial Sloan Kettering group has conducted a study with mRNA vaccine, and we know that the neoepitopes that these vaccine targets are mostly KRAS types of epitopes. A phase 3 study, actually phase 2 randomized, is completing accrual imminently that randomized patients with pancreatic cancer after surgery to the mRNA vaccine versus just observation, and this is in addition to adjuvant FOLFIRINOX. Another type of approach is a off-the-shelf KRAS-specific amphiphil vaccine that is supposed to really activate immune cells within proximal lymph nodes for patients with pancreas cancer. Amplify 201 study has shown very promising relapse-free survival for patients with ctDNA positive or positive molecular markers for pancreas and colorectal cancer, and a phase 2 study with this vaccine, this type targeting 7 different KRAS alleles, had been, I think, just completed, Amplify 7P.